So let us talk about damage control orthopedics. What is the definition? What do you focus on? What is the priorities? How do you determine adequacy of resuscitation? And when do you do the definitive care? So let's start with the definition. In damage control, we use an approach to treat the multiple trauma patient by staging the definitive management. And we do that to limit the cumulative trauma. So the trauma is associated with a surge in the inflammatory mediators. The peak is usually about 2.5 days post-trauma, and that is the first hit. So we will delay the definitive management until the acute inflammatory window is closed, so we avoid and limit the second hit. We avoid provoking a severe inflammatory response, and at the same time we provide sufficient stabilization of fractures and prevent tissue damage, and we stop the hemorrhage, we restore the circulation or the perfusion, and we eliminate contamination of wounds. This is the area we focus on. So by adopting this damage control, we will decrease the impact of the second hit and will avoid adding more trauma to that vulnerable patient. And the definitive care is delayed until the condition of the patient improves. In this case, you will use external fixators for the femur and the tibia, and the splints for the forearm and the humerus. In the femur, you can leave it up till 3 weeks. In the tibia, you can leave it up to 10 days. In the tibia, if the treatment is delayed or if there is spin tract infection, then you got to do a staged conversion. In the pelvis, look for the word binder. You need a binder. And in multiple trauma, you will delay the surgery for 7 to 10 days. So we use the damage control when the patient cannot be adequately resuscitated. The patient is acidotic, hypotensive, hypoxic, hypothermic, patient have coagulopathy. You're going to use external fixators. The leukocytes are primed by the initial trauma, by the primary trauma. So the early total care in a sick patient may not be appropriate. Actually, it may bring severe complications to the patient, such as ARDS and multiple organ failure. So what are the parameters that will help us to decide which patient should be treated with damage control orthopedics? ISS score more than 40 without thoracic trauma, ISS score more than 20 with thoracic trauma, Glasgow Coma Scale of 8 or below, bilateral femur fractures, pulmonary contusion as seen on x-rays, multiple injuries with severe abdominal and pelvic trauma and hemorrhagic shock, hypothermia less than 35 degrees. Patients with severe head injury are at risk of hypothermia, and if the INR is more than 1.5, patient could be in DIC. And the last group is head injury patients. In head injury patients, the drop in the systemic blood pressure may lower the cerebral perfusion and compromise the brain function. So this group of patients will have damage control orthopedics. Defined reduction in the rate of ARDS and multiple organ failure with the use of damage control orthopedics. So let's review that again. The first hit is the trauma, which will give us systemic inflammatory response. So you'll have cytokines and prime leukocytes. That's what the surgeon is facing with. So if the surgeon is doing an early total care, especially with arm rods, and we know reaming is bad, have systemic effects, in this case you will have lung surgery with blood loss, fluid loss, more cytokines, more activation of the coagulation system. Then you get a second hit, the surgical blood loss. Surgery represents the second hit, and it will exacerbate the systemic inflammatory response. That primed immune system in that patient have a huge ability for response. With primed leukocytes, that will cause tissue and lung injury, and we want to avoid this by damage control, because we control the situation now. We say yes to surgery or no to surgery, yes to small surgery and no to big surgery. So we stage the treatment, damage control. This acute inflammatory window is considered to be between 2 to 5 days. That's when most of the surges in the inflammatory marker occurs during that time, and only potentially life or limb threatening injuries can be treated during that time, like compartment syndrome, fracture with vascular injury, or unreduced dislocations, or open fractures, or long bone fractures, or unstable spine. If timing of the surgical intervention is not appropriate, you can get the second hit with acute tissue and lung injury. If the patient is stable, they will go to the OR. If the patient is not stable, the case will be delayed. But this borderline patient, the patient probably will benefit from the delay in surgery. This is the patient that will benefit from damage control orthopedics. So what are the prime inflammatory mediators released after trauma? It will include the interleukin 6 and 8. You do not want to push the patient towards ARDS or multiple organ failure by creating more mediators secreted, because we doing surgical intervention that makes these mediators increase in production and in the ability to produce more damage. So these cytokines are secreted by the macrophage. The IL-6 is a potent inducer of the acute phase response. The cytokines are responsible for triggering the inflammatory cascade, promote abnormal attachment of the leukocytes to the endothelial cells that line up at the arterial lumen. The macrophages secrete IL-6. It's also produced by T cells, by dendritic cells, by endothelial cells in response to trauma to stimulate the immune response.